So I originally trained as a clinician, and that's the perspective I'm going to bring to this morning's meeting, I think, or at least this morning's session. So thank you. I think that's what everyone's seeing. Yes, so right, I'm sorry. You'd think I'd be experienced at this, wouldn't you? But I'm feeling like a deal, so I apologise for that. So look, the first point I'd like to make is that when you introduce the concept of using these antibacterial viruses as therapeutic to clinicians, the only reference point is the use of chemicals, drugs, antibiotics. And so we're used to the concept of something, diffusing in a lawn of agar, a bit like what we call a spot test or a plaque. It looks like it, but it's nothing like it. And then the idea of the efficiency of plating, in which it's really a function of the reference strain, and it looks like it, but it's nothing like anything we would use in drug testing. But growth inhibition, I guess, is the nearest thing we've got to what clinicians or clinical microbiologists would be used to seeing. But it's not yet clear at the moment what that looks like, whether that lag phase that you often see when something's not completely flatlined, whether that is going to prove to be predictive of clinical outcomes, really remains to be seen. So the reference point of a susceptibility test, I think, is a little problematic still in phage therapy. This is something that you'll hear from the clinical microbiologists. The other thing that doctors and I think regulators worry about, which is worth highlighting because I don't think it's entirely clear, is this fixation on the so-called obligolytic phage. Now, the definition of that, most of us use a genomic definition of that, the absence of classic chromosomal integration equipment, and the regulators are increasingly looking for reassurance that that is the case when they're looking for a therapeutic offering. And I think it's important for the research community to think a little bit about whether that is really necessarily true and whether we really need to exclusively work with obligolytic phages. But it's certainly an assumption that is made because all the clinicians are used to the idea of phages bringing virulence to classic pathogens like diphtheria or Staph aureus or cholera or Shigella. And so this has become almost a sort of law, L-O-R-E, in the clinical space, but is something that we possibly need to challenge. I think one of the third great assumptions is the search for synergy. This is important because at the moment, for therapeutic purposes, we're almost always using phages in the presence of antibiotics. Unless and until there is widespread application of phages alone for anti-infective purposes, we will not accumulate a lot of experience in humans who are unwell with phages being the sole therapy. The only real circumstances we see that now is someone who has terrible antibiotic resistance. So that, to some extent, that experience will start to accumulate. But the definitions of synergy and what they mean at the bedside, I think, are very important. Certainly at the moment, most places that are providing therapeutic offerings will be, certainly we do, will be routinely testing for the presence of synergy and antagonism, for that matter, in growth inhibition in vitro before offering this as a therapy. The difficult question of phage synergy we're not going to touch on. I don't know if there'll be sessions in this meeting about that, but the nature of those interactions, at least in the way they're presented to the clinicians, are very limited. These are not really described in great detail in most of the clinical offerings that you get. But this is increasingly an expectation that phage or phage antibiotic synergy in vitro will be offered, even if we don't quite understand the clinical implications yet. So I thought it would be useful to hark back a bit on our own initial experience with using therapeutic phages in a group that was reasonably homogeneous, or as much as you can get, because there's a bit of a lack of homogeneity in the clinical experience at the moment. And this is a group of people who were included if they were persistently bacteremic with Staph aureus. Now, in this little slide here, you can see on the vertical axis, you can see the bacterial load in genome equivalents per mil. So this is a qPCR-based assay. It's not a growth assay. On the top, you can see bars. Those bars represent individual patients who are persistently blood culture positive, and the little dots that follow are the DNA in you, if you like, the genome equivalents detected in the bloodstream. And the reason I show you this is because the phage therapy, which was for 14 days, continued in many of these people in the presence of an active bacteremia. So this is the circumstances in which you are seeing co-circulating bacteria and viruses in the bloodstream of a very sick patient, where you would expect to see some sort of resistance evolving. And I think it's an important point to make that in this setting, it's actually relatively unusual to see phage-resistant bacteria arise. And that we can talk a bit about why that probably makes some sense. But many of us, first clinical experiences or first clinical reports talk a lot about what we see, of course, which is easy to produce in an epidural, which is induced phage resistance. But we don't see so much of that in clinical medicine. In this particular setting, what we've got is a Staph aureus bacterium, as I said, 3 K viruses very closely related, used together. It was a GMP-like therapeutic preparation, commercial preparation, and they've been published, so it's easy to look at those. This was our first experience, and at this stage we could see in Australia that we were starting to get people importing therapeutic bacteriophages for applications in extreme circumstances where someone clearly needed rescue, and this is still the commonest scenario. And so we formed a bit of a national consortium, which we imaginatively called Phage Australia, and our purpose was to establish best use cases and to try and understand how we could use this therapeutically and to measure what we were doing properly. It's really fairly representative. Most of the big capital centres, capital cities, I should say, the big metropolitan teaching hospitals are included, and all the children's hospitals are included in this network, so it's fairly comprehensive. And of course, I should point out that many of the people in this room and many of the international collaborators have contributed very generously to our initial attempts to try and respond to Australian clinicians who are seeking therapeutic phages. So, I said before, we were measuring what we were doing as we went to try and understand how we were going. And so the other thing that we routinely measure, apart from the bacterial load in the bloodstream, is the phage load in the bloodstream. So we're trying to consistently give the same amount, that is the same sort of dose and the same sort of dosing strategy to understand what's going on. And we certainly see quite reproducibly, it seems, this peak in pre-dose kinetics. So this box on the left that you can see is a couple of mycobacterial phages from Graham Hatfield's lab that was used to treat Rebecca, who's a little inset at the bottom, who's a young lady who had Mycobacterium abscessus, which is a really common request for phage therapy in a setting of cystic fibrosis. And you can see that by about day 8, the sampling of her blood just before she was redosed showed this significant increase in one, or in fact both of the phages that subsequently subsided. So at the end of that week, and in fact for most of our patients, you can see, for example, from Pseudomonas, a single Pseudomonas phage on the right-hand side, which was sourced from around near Paz and Ronan Hassan at Hebrew University, to treat a young lady with osteomyelitis. So very different clinical setting, very different pathogen, different virus, same kind of scenario. A strong amplification response, that's that big blue peak, at around about the 4 to 8 days mark. And if we focus on this a little more closely, I think it's instructive. We have as I said, an osteomyelitis infection, so it's a very nasty bone infection caused by a very resistant pathogen, which is why we could justify using what's regulators regard as experimental therapy. And she had a dramatically salutary clinical response with a bone infection on the top. This is an MRI scan where white bits, or all the bone edema or inflammation, dramatically settled over the space of a couple of months of therapy. After 2 weeks of phage therapy, she settled down steadily. But the point I want to make here is that you can see this big amplification response, or people sometimes refer to as, this auto-dosing response. But I want to point out a couple of other things as well, and that is that there were a couple of spikes of Pseudomonas aeruginosa genomes in her bloodstream. This is a little girl who'd never been bacteremic, wasn't particularly systemically unwell. She was out in the community just getting antibiotics. And the slightly noisy graph, but the vertical arrows you can see of the phage dosing, the paediatricians timidly started with 1 dose a day. The taller arrows are 2 doses a day. The green bars you can see at the bottom, if you're following my cursor, I don't know if you can see a cursor, but in any case, the green bars at the bottom are the number of viable phages we were able to retrieve from serum. So you're talking about a small numbers, 2 logs basically. And that's a common scenario we see only for the first few days. And again, this is pre-dosing. So we take this sample immediately before redosing with phages, and then they disappear. But the key point is that soon after her first dosing, she had a bit of local pain, a bit of temperature, and a spike, which is this grey thing of her C-reactive protein, which is a surrogate of IL-6 production, if you like. So she had this inflammatory syndrome. At the same time, we detected Pseudomonas aeruginosa DNA in the bloodstream, and the same thing happened again when the dose was increased about day 8. So we have these 2 spikes of Pseudomonas aeruginosa into the bloodstream after phage administration, associated with a bit of clinical symptoms and some inflammatory responses. So I referred to dosing and trying to standardise. We have attempted to try and harvest data by standardising as much as possible. We've settled on about 10 to the 9 PFU, which is a common dose people use, I think. And it's hard to rationalise this stuff, but you can do a bit of crude arithmetic in your head, and it works out to be something like 1 to 10-fold higher after dilution into a 5-litre blood volume than the typical number of bacteria that you would find in the bloodstream in severe sepsis, which is typically anything between 10 to the 3 to 10 to the 5 CFU. We know that's cleared quickly within hours. We know from animal data, at least, that this is all reticuloendothelial clearance. And we know that the qPCR, which I've been showing you before, shows that by really clearing by about the 12-hour mark. And I've pointed out the amplification that we so commonly see in about the 4 to 8 day mark. But what about immune responses? We'll hear from Professor Gorski, no doubt, or maybe not this morning, but he's certainly spoken about before, the immunomodulation question. I'm not going to address that because it is very hard to see this in the very noisy and very heterogeneous clinical environment that we're working in. But that is an interesting question for the future. What I can show you is that if you do a cluster analysis on the upregulated and downregulated genes that you can see in the human inflammatory response, so this is RNA-seq data, you can see very clearly that, again, this is just before redosing, that early in treatment, you get this quite dramatic clustering of a change in responses. You see mostly this in the innate immune response, particularly TLR4 type pathway response genes. And you can look at this data in great detail and analyse it yourself if you go to that reference. But to just summarise the findings, essentially we see this initial sort of innate immune response, and then the subsequent, about the time that you would expect, an upregulation around about day 5 to day 7 of the adaptive immune response. And this appears to be reflected in neutralising antibody development. So other people have described this, but certainly just sticking on this one particular anecdote, which we looked at in detail, you can see that we've got about 3 to 6 logs drop in EOP if you apply serum in a 50-50 ratio. So that's about equivalent to, a blood exposure. And that occurs within about 7 to 10 days, which is exactly the kind of time which you would expect to see a neutralising antibody response develop to other viruses that we're more familiar with. And this is the Staph aureus data. You remember I mentioned that we looked closely at 13 or 14 humans who had a very severe staphylococcal infection. Their neutralising antibody data, this is a bit more compressed, this data, but they were all doing much the same thing. You've got about 6 logs of drop by about day 10 to 14. This is important because it probably limits the therapeutic utility of those particular phages. You probably get most of the bang for your buck in your first week or so. Noteworthy is this one at the top, this pale blue line. This is a person who was very immunocompromised. And I think what we're consistently seeing is that in people who are immunoablated, so bone marrow transplant patients, that sort of cohort, where you don't expect them to have the immune response, you may not have this same limitation through neutralising antibody development. And certainly this has been reported by others, so I don't think this was particularly a big revelation to everyone, but I think it's important therapeutically, and it probably does modulate the approach you take to therapeutic delivery of phages. So I said before that we'd really gathered together the clinical community a bit. We asked them the question about phages. What do you think is most important? What would you like to see dealt with? Where do you think the problems are? And these sort of forget the term for it, the word pictures, basically the size of the writing gives you a feel for the number of responses that we got. It was a national survey of Australian infectious diseases physicians. 90% of them said, look, you think this is safe if compared properly. We don't know if it works. We want you to give us some structure so that we can understand that. I think that's really important. The physicians really wanted to see some clarity around protocols, around logistics, more timely access, and they wanted to see everything that was done closely scrutinised and the data promulgated for review. So we set up this sort of trial, which is really a process trial. I had a bit of trouble publishing this actually because it's not an RCT. We used a clinical trial framework because I wanted, to be blunt, I wanted the punitive structure that comes with the clinical trial framework. One of the curses of this, and many of you will have experienced this, is you get calls for help. Please give me some phages because I've got to treat this person who's desperately ill. And you say, please give me some data because we've got to understand what you're doing with this stuff. And you don't hear back a lot of the time. So we had to have a way to make sure these data were being collected and that these data were being safely managed. So we built an informed consent structure, a classical clinical trial structure with rigorous gatekeeping, and I think this has served us well. I'm not going to spend a lot of time on this slide because I think it's pretty straightforward. We try and make our therapeutic offering look as much like a normal prescription as is relevant. So we have a diagnostic assay we produce that looks a bit like an antibiogram. Now, of course, there are these caveats about how you describe phage susceptibility. So we normally present all the data that we've got and we make a subjective remark about whether we think it's appropriate to proceed with the phage on the basis of that information. We then provide sort of largely genomically based assessments of the phage that we're using, or the phages that we're using, the production strain that it's being made in, because we don't have, outside of E. coli, there's no really good standardised assessment of the kind of proteins that you might co-purify, or in this case, minoprophages that you might co-purify and administer to the patient. So you have to just declare this up front, I think, and try and provide an intelligent assessment of what it really means. And of course, a manufacturing safety commentary, you know, this is clean, this pH is okay, it doesn't have the Black Death or HIV growing in it as well, all those sort of obvious things that you would do for any therapeutic preparation. We've asked for some sort of an independent assessment about whether this is viable, because governments are asking the question now, is this a waste of money or is this a bit of a winner? And if you price bacteriophage production This was a bit of a guesstimate, but we priced it at about $25,000 per batch. So for you, that's probably about 12 to 15,000 sterling. If you did that in a country like Australia, and if I extrapolated all this to UK, using the data that we had presented to us, you would probably be saving something like 120 or 150 million pounds per year if you just implemented the infected hip and knee replacements, assuming only 55% efficacy, which was the published data that was available. And I know these are not good data, they're not RCTs, but that's the assumptions that we drew from. And if you compare them with what governments spend money on, that's really helpful as well. So using that same sort of extrapolation, if you look at intensive care services, bone marrow transplant services, kidney transplant services, they are clearly below the cost effectiveness threshold that the Australian government draws, which is about $35,000 to $40,000 per quality adjusted life year saved. So the quality adjusted life year concept is something that health economists are familiar with, but essentially it's one thing to save a life, but if you save a life and make someone absolutely miserable with the process, you know, they've got a lot of pain, they've got a lot of disability, that's not a high quality outcome. And so if you adjust for that, you get a feel for what's good value and what's not good value. We've known for years coronary bypass grafting is a bit meh, and so that makes sense. You know, the bone marrow transplants and ICU services are great value for money, and Phages, the assumptions that I just made, are about that level. And that's really important because if governments believe that, if we can tighten up those data, it is a clear, good value investment for a country. And it's sensitive to economies of scale. I don't need to tell you that. I don't need to labour this point. But obviously, because this is batch production, this is bucket chemistry to some extent, you can make a massive batch, and if you can only use it, it's cheap as dirt. But of course, most of us are being asked for one-offs. Please save this individual. Okay, so make a batch. It's, you know, it might be 30 doses or something at 10 to the 9 PFU twice a day, and then the rest goes down the drain, and it costs you 25, 60, who knows, lots of money to do that. But if you can just predict in advance what you're going to need, and the shelf life's enough for you to meet that demand, then you start to get into this window. You only need to use about 10% of your batch to get a serious economy of scale. And that's a really important thing. That's a lot to do with selection, predicting volume, and that's why I say, I won't talk about it much today, but why it's important to be linked with surveillance programs. So what we do, just to summarise now, winding up, is we focus on life and limb criteria because that's what everyone, is doing at the moment. We require expert referral within scope of clinical practice, so we don't want respiratory physicians prescribing for bone infections. Everyone has to stay within their box, and that's certainly something that we stipulate inside our clinical trial framework. Mentioned that we try and standardise the data collection. That's really important. Pharmacokinetics is really important data to glean at the moment, and we need this feedback, including the host immune response, I think. We're assuming, and I think with some justification, that it's safe if you prepare it properly, and it's clearly effective in certain circumstances. We think we should use non-integrating phages. I think that is something that could be challenged. Neutralising antibodies, dosing, synergy testing, I think these are probably starting to clear up in terms of understanding what we're doing. I think the current in vitro measures of activity concern me a little, but I think they're probably fit for purpose. So we've got more questions and answers. And I need to thank, you know, the team who supported us right around Australia, a big network, and particularly the people, including the people in this audience, who've really been so generous with their expertise, their time, and their material.